Hi friends. In the previous video, we have discussed about the obstetrical emergencies. Here, we are going to see one of the obstetrical emergency, that is amniotic fluid embolism. Amniotic fluid embolism means amniotic fluid enters into the maternal circulation and it reaches the pulmonary capillaries. This amniotic fluid can enter into the maternal capillaries if there is a tear in the amnion or chorion, or if there is an opening in the maternal circulation, or if the intrauterine pressure is high. In these cases, the amniotic fluid may enter into the maternal circulation. The risk factors for amniotic fluid embolism include advanced maternal age, multiparity of the mother. In these cases, the muscles won't be having proper capacity, and meconium staining. That is, in that case, excessive struggles will be there for the baby. So there is a chance for there is a chance for mild leakage. Cervical laceration, that is, if there is any mild tear or injury, through that the amniotic fluid may enter into the maternal circulation. Intrauterine fetal death, in that case also, when the date is getting postponed, the capacity of the muscles may decrease. And another thing, decay or the layers or covering of the baby is amnion and chorion. This amnion and chorion also may get decayed. So there is a chance for leakage of the fluid, and that leads to the entry of this fluid into the maternal circulation. And if the uterine contractions are very strong and frequent, that may force the amniotic fluid into the maternal circulation. And another one is sudden fetal expulsion, that is precipitate labor. If the entire process is getting completed in 1 hour, that is known as a precipitate labor. So suddenly the baby will be coming out of the uterus. In that case also, the uterine contractions will be more, and when the pressure of the contraction is more, there is a chance for pushing of the fluid into the circulation. And another one is placenta accreta. That is, morbid attachment of the placenta is known as the placenta accreta. In that case, later when the placenta is getting separated, of course, when the placenta is getting separated, there will be an erosion over the uterine endometrium, and through that eroded part, sometimes the amniotic fluid may enter into the circulation. And another reason is polyhydramnios. In the case of polyhydramnios also, the pressure inside the uterine cavity will be more. So there is a chance of forcing. When the pressure is more inside the cavity, the fluid may get forced into the maternal circulation. And another reason is uterine rupture. Already I have told you about the cervical lacerations. Same way, even here also, when the membranes are getting ruptured and when the uterus is getting ruptured, of course, there is a chance for entry of this amniotic fluid into the maternal circulation. And next one is history of allergy and atopy. In that cases, if there is a mild irritation or allergic nature is there also, when a mild drop of fluid is entering into the circulation, that may trigger the condition of the mother. And next one is chorioamnionitis, that is inflammation of the chorion and amnion. So due to that inflammation, its protective capacity, it is getting infected and it may get damaged, so its protective capacity may decrease, and it may allow the sweepage of fluid. And fetal macrosomia, in the case of fetal macrosomia also, chance for pressure inside the cavity is more, and that may leads to the leakage. And another reason is male fetal sex. See, we are not sure that in the case of male fetal sex it will occur, but there is a chance, or the chance is more in the case of male babies. And the studies are telling that the male babies may be more active inside the uterus, so that may leads to the entry of fluid. And another one is injudicious administration of oxytocin. That is, if you are administering oxytocin excessively, that may produce severe and strong uterine contraction, and that may contribute to the amniotic fluid embolism. But all these things, we cannot tell that all these things will cause the amniotic fluid embolism, but these things may cause the amniotic fluid embolism. Next, we can see the pathophysiology of the amniotic fluid embolism. Actually, the exact pathophysiology for amniotic fluid embolism is unknown, but nowadays we are believing in the biphasic model. It is suggested by the Cotton in the year of 1996. And in the biphasic model, they are telling that in the phase 1, amniotic fluid is, because of one or other reason, amniotic fluid and fetal cells will enter into the maternal circulation. When it is entering into the maternal circulation, it will produce certain biochemical mediators in the maternal circulation. Certain allergic type, see, when if you are allergic to something, when that substance is entering into the body, it will produce certain antibodies. Same way here, certain mediators will get generated in the maternal circulation. And these mediators will produce pulmonary artery vasospasm. That is, it will produce a constriction of the pulmonary artery. So naturally, when the blood vessels are getting constricted, what will happen? It will produce hypertension. So that leads to the pulmonary hypertension, and that leads to elevated ventricular pressure. When it is getting narrowed, pressure will be more. And when it is narrowed and pressure is more, the hypoxia, that is lack of oxygenation, will occur. That is reduced amount of supply will occur, and that leads to the hypoxia. And that hypoxia may produce myocardial and pulmonary capillary damage. Absence of oxygen for a long period may produce damage, and finally it may produce the heart failure. This decreased circulation and hypoxia may produce the heart failure, and later it will produce acute respiratory distress syndrome also. And in the phase 2, these same biochemical mediators, it will stimulate the widespread coagulation, that is disseminated intravascular coagulation. In almost all the part of the body, the blood will get coagulated inside the blood vessels. And when it is getting coagulated, we know that it will be using maximum amount of clotting factors and platelet also. So later what will happen? All the clotting factors will be utilized by this for this process of disseminated intravascular coagulation. So platelet count and clotting factors amount will be decreasing, and that leads to the hemorrhagic phase. The lady will get the massive hemorrhage. Even if you are trying to insert a needle, from that needle site also the mother will start to bleed. This is the pathophysiology of the amniotic fluid embolism, or we are believing that this is the pathophysiology of amniotic fluid embolism. Next, we can see the signs and symptoms. Actually, it will occur in the following sequence. First, respiratory distress will occur, then cyanosis, bluish discoloration of the skin and mucous membrane will occur, and later the person will go to cardiovascular collapse and shock. Later, I have told you that disseminated intravascular coagulation will occur, and because of that, hemorrhage will occur. Finally, the patient will go to a stage of coma. And in the clinical presentation, if you are observing the mother, there will be a sudden drop in the oxygen saturation. See, even if you are performing the cesarean section also in the theater, there itself, you can monitor. If you are monitoring, you can see the oxygen saturation of the mother will come down suddenly. That will be the first sign. Then later, most probably what will happen means within 1 hour or within half an hour, the patient will die. In case if they are surviving also, the 50% of the patients will develop disseminated intravascular coagulation, and later that may lead to the profuse bleeding. And this coagulopathy, that is disseminated intravascular coagulation or DIC, is occurring within half an hour to 4 hours. And later, few patients may develop seizures, and in the chest X-ray, you can see, sometimes it may be normal, or sometimes you can see effusions, enlarged heart, and pulmonary edema also you can see. And if you are taking the ACG, it may show right strain pattern, or it will you can see changes in the ST segment, and tachycardia also will be there. And next we can see the laboratory investigations. You can go for the complete blood count. You can check the coagulation factors, fibrinogen level, arterial blood gas, chest X-ray, electrocardiogram. You can perform the scan. It will help even for you to locate the size of the emboli, echocardiogram, cervical histology, serum tryptase, zinc, corprophyrin. All these things are the investigations you can do for confirming the diagnosis. And next we can see the management of amniotic fluid embolism. Actually, we are just doing the symptomatic management for saving the life of the mother. First, you should start the CPR if it is necessary, and you should start an IV line. You should resuscitate. You should arrange all the equipments for the intubation and all the measures for managing the shock, and you should arrange the emergency medications. You should call for help. You should arrange a pediatrician, obstetrician, surgeon, everybody should be available over there. And first itself, you should start an IV line and you should start the oxygen administration. Once if the airway is under control, it's okay, you can continue with that. Otherwise, you should go for the intubation, endotracheal intubation, and that will provide maximum ventilation and oxygenation. And next you should go for the investigations, laboratory investigations. You should go take the arterial blood gas level, CBC, platelet time, prothrombin time, fibrinogen, everything you should perform. In the management, in order to treat the hypotension and for increasing the circulatory volume and for increasing the cardiac output, we can give crystalloids to the patient. And for the correction of, once if the hypotension corrected, once if the blood pressure become okay, we can reduce the fluid intake or we can restrict the fluid intake, because there is a chance for respiratory distress syndrome in 40 to 70% of the cases. So once if hypotension is okay, or once if the patient is coming to the normal blood pressure, we should restrict the fluid therapy. And for some cases, we used to give the steroids, but the exact reason for giving steroids, we don't have any particular evidence for showing that steroids are highly effective. And for reducing the hypotension, for treating the hypotensive patients, we can give the dopamine, and for giving myocardial support also. And the vasopressor also we should start. The vasopressors like ephedrine, levetiranolol, we can start for the patient, and it's of great success, and it will reduce the vascular resistance, systemic vascular resistance also. And for the effective management, continuously we should take the ECG, we should assess the partial pressure of oxygen, we should see the carbon dioxide saturation, a partial pressure of carbon dioxide, and we should assess the urinary output of the patient. And if for assessing this, we can start central line, and you can insert pulmonary artery catheters, and you should insert the urinary catheter. And by these ways, through these catheters or through these lines, you can assess or you can monitor the urine output, oxygen saturation, level of carbon dioxide, everything continuously. Central venous pressure monitoring is important in order to diagnose right ventricular overload and guide fluid infusion and vasopressor therapy. Blood can also be sampled from the right heart for diagnostic purpose. So for these reasons, we can start the CVP line. And pulmonary artery and capillary wedge pressures and echocardiography are useful to guide therapy and evaluate left ventricular function and compliance. An arterial line is useful for repeated blood sampling and blood gas assessment and to evaluate the efficiency of the resuscitation. And management of coagulopathy. I already told you that disseminated intravascular coagulation will be there. That leads to the decreased amount of fibrinogen, platelet, and coagulation factors, especially factor 5, 8, and 13. So the fibrinolytic system should be activated. So for these patients, most of the patients will be having hypofibrinogenemia and abnormal PT, prothrombin time, and platelet count also will be there. So for treating this coagulopathy, we can give cryoprecipitate. If the fibrinogen level is less than 100 milligram per deciliter, we can give cryoprecipitate. And if the platelet count is less than 20,000 millimeter cube, we can give the platelet transfer. We can start the transfusion of platelet also. And for restoring the uterine tone, usually uterine atony will be there. So it can be restored by the massage, packing of the uterus, and by giving oxytocin and prostaglandin. But when we are giving prostaglandin, we should be careful, because the prostaglandin may affect even the, or it may produce contraction of the blood vessels and bronchioles. So you should be conscious when you are giving the prostaglandin. And cardiac output and uterine perfusion also should, if it is increasing, automatically the uterine tone will increase. So naturally, when we are giving fluid therapy and when we are decreasing the hypotension, and when you are managing the patient, naturally the uterine tone will increase by restoring the uterine perfusion. For increasing the myocardial contractility and for replacing or restoring the systolic and diastolic blood pressure, we can start to give the dopamine. This dopamine will increase the renal blood flow, and by that way it will increase the glomerular filtration rate also. The dose of dopamine is 2 to 5 microgram per kilogram per minute per IV. The contraindications for the dopamine use is if the patient is having ventricular fibrillation or if severe hypovolemia is there. In these cases, you should not start the dopamine. And the precautions that you should take when you are giving the dopamine includes you should monitor the urine flow, you should monitor the cardiac output, and you should assess the blood pressure during the infusion and prior to the infusion. And if hypovolemia is there, means you should correct it either by giving blood or by giving plasma. And when you are giving it, you should monitor the central venous pressure, and left ventricular filling pressure also should be monitored. So that's all about the dopamine infusion and management of amniotic fluid embolism. Now we can see the complications of amniotic fluid embolism. Already we have seen it is DIC, that is disseminated intravascular coagulation, acute renal failure, hypovolemic hypotension, perinatal mortality and morbidity. Thank you for watching this video.